yesterday, this is going to be the final lecture of this course, and this will be covered in your final exam. It also covers the competency that you have next week. The last two comps are going to be for cervical and lumbar spine. Any questions before we get started? Questions, okay. All right, so this is chapters 14 through 16 of your Kisner and Colby book. We start with a little bit of an introduction to a little bit of the anatomy of the spine. Should be a review for you. You should bring this from intro, also from kinesiology. So I would suggest you review some of the information if it's unfamiliar to you. Okay, so the trunk and spine is known as, obviously, it's going to be our largest segment in the body. It has the most significant functional movement for general movement. We know that each section moves on its own to an extent, but they kind of require each other to move in that general significant movement that we do. It plays an integral role, a very important role in upper extremity and lower extremity function. And we know that there's very little to no movement, very little movement in regard to two vertebrae, one on top of the other. So the isolation of one over the other might not be possible for most of the spine. Only in the, I would say maybe in the upper cervical, we can go ahead and move the discs, but if we go any lower, there's not really going to be that much movement between two vertebrae. Just to review once again, the vertebral column consists of 7 cervical vertebrae that develop as an infant, begins to lift its head, 12 thoracic vertebrae that are present at birth, and 5 lumbar vertebrae that develop in response to weight bearing. And we have the sacrum, which consists of 5 fused vertebrae, and the coccyx, 4 to 5 fused vertebrae as well. If you ever get the amount of vertebrae that there are, something that we use is breakfast at 7, lunch at 12, dinner at 5. Just to kind of remember the 7 cervical, 12 thoracic, and the 5 lumbar vertebrae. Sacrum and coccyx, really can't forget those. So as you see here in the picture at the bottom, each vertebrae kind of changes, the shape changes. It changes to reflect the amount of movement that is going to be needed within that given section. As you see, the lumbar gets a little wider, there's a little less movement in the lumbar spine, so it needs a little bit more support, which is why it widens, it gets wider. The foramen widens, the bodies become wider. Then you look at the thoracic, it's a little bit less, it's a little smaller than the lumbar, and then we have our smallest one, which is the cervical, which provides the most mobility. We're going to be looking at the mobility at each level so that you can see how it differentiates all the way up from cervical to the lumbar spine. So we're going to be looking at impairments, we're going to be looking at postures, but it is important to know that impairments in the joints, in the muscles, in the patient connective tissues can lead the patient to have postures. So an example of that would be a patient that's has osteoporosis, and it's been progressing for several years, and the patient is taking that posture, that rounded kyphotic posture. This is due to the impairments that is going on in the patient. Now, on the other hand, if we have a patient that doesn't have an impairment, but is somebody, as here in the picture, let's say here on the top picture that I'm pointing to, this patient is continuously 8 hours a day in that same stoop posture. So that's a faulty posture. He needs to maybe have a lumbar roll behind his low back to kind of promote that optimal posture. So this patient has very faulty posture. So that faulty posture for that time, 5 days a week for 8 hours, is going to lead to impairments in the joints in the muscles and in the connective tissues. And it's obviously going to be accompanied by pain and some discomfort. So just to summarize this slide, basically a condition or a pathology or an impairment that's going on within the spine can lead the patient to have bad posture, but also bad postures when held for a certain amount of time will lead to those impairments in the muscles and the connective tissue. So this patient that I just pointed to or that I talked about, all that stooping to look at the computer will tighten the muscles in the front, will lengthen the muscles in the back and weaken them. It can also have an effect on the ligaments that are holding the spine upright. It can also have they can also have pain due to that pressure that he is doing for extended periods of time. So did everybody understand that it can go both ways? Okay, perfect. So just a very brief review. Why is it important for us to know where the vertebrae articulate, where there's muscle attachments? Important. Why do you guys think it's important for us to kind of go over the entire articulations and where everything attaches? Any idea? Wake up, everybody. So it's as simple as, well, I don't know if some of you are typing, but it's simple as just knowing exactly where the impairments are going to be located. So if it's muscle tightness, you need to find out, you need to know where that muscle attaches or where that muscle originates so that you can know, okay, tightness of the muscle is going to pull on its origin, it's going to pull on its insertion, so it's going to maybe shift some type of joint that is it's being attached to. So we have to know exactly the anatomy so that we know what we need to do to get the patient back to how they were before. So we start with our vertebral articulations. You know that each articulation is a fully encapsulated synovial joint that they're often referred to or called apophyseal joints. We have here our superior articular process, our inferior articular process, and this basically just tells you that it's going to connect to the vertebrae above it and the vertebrae below it. So this is where they kind of fit like a puzzle. Okay, so sometimes there's conditions that, let me go back to the slide and just give you an example. So there can be a condition where ankylosing spondylitis, where I don't know if you guys, I think you guys covered it in medical diseases, where it's kind of also referred to as bamboo spine. So the spine kind of fuses together. Or it can just be simply a buildup of bone spurs in this area, which will obviously decrease the height of the vertebral bodies. So it's important for us to know where it is that the vertebral bodies articulate with one another, because these conditions will affect these areas here. Then we have our costal or our rib articulations. We have the superior costal facet where the ribs attach. We have the inferior costal facet. We have the transverse costal facet. Also very important to know that the ribs attach to this area. So a rib fracture may affect the articulation. So that's why we're kind of breezing through and covering all of the possible locations in the spine and the vertebrae that can be affected by a condition or by an accident or trauma. Just a brief overview of the body, the vertebral bodies. We have the body here. We have our transverse processes. We have our vertebral foramen. What goes through that vertebral foramen? The spinal cord, good. Right, we have our intervertebral foramen, which is where our nerve roots go through. So any degeneration, any type of stenosis or narrowing of the vertebral foramen, we're going to talk about as a condition, or narrowing intervertebral foramen is going to cause impingement in the nerves, and it's going to send down nerve like symptoms down the leg, or even if it's happening in the cervical spine, it could send paresthesia, tingling, numbness down the arm if it's happening in the cervical spine. So it's very important for us to know the anatomy and what changes or modifications or accidents can do to this anatomy and how this is going to present in the patient. We also need to know the muscular attachments. So the muscular attachments, there's muscles that attach on the spinous processes, there's muscles that attach on the transverse processes. Very, very important to know because obviously tightness in the muscle may be pulling on this spinous processing, may be pulling on this transverse processes. So it's very important to know what muscles attach where and what we need to do to stretch those muscles, which we're going to learn in lab how to stretch and how to strengthen and stabilize all muscles that support the spine. The intervertebral discs are the shock absorbers of the spine. I always refer to them as the meniscus of the spine. Pretty much they do what the meniscus does for the knee in the spine. They absorb that shock that we constantly on an everyday basis put on our spine. Just by standing, we're putting pressure on the spine because gravity is acting upon us, and our intervertebral discs act as a cushion to kind of prevent those forces from taking a toll on us. They're capable of withstanding compressive and torsional forces, so the rotations, bending. Their main role is to bear and to distribute the loads in the vertebral column and to prevent any excessive motion in vertebral segments. So they're the cushion to our spine. So digging deeper, now we're going into what's between those vertebral bodies, and we're talking about the nucleus pulposus, which is a gel-like mass that's in the center of the discs. It's always under pressure, which kind of keeps a little bit of tension in the disc so that it preloads it. That's what it means. It's just all going to provide that nice cushioning. It's always going to be under a certain amount of tension to provide that springy cushion that it requires to have between the discs, between the vertebral bodies. 80% to 80% of it is made out of water, 15 to 20% is collagen. I do not expect you to remember. I'm not going to test you on 80 to 90% being water or 50 to 20% collagen. That's just another fact. Okay. Then we have the annulus fibrosus, which is that ring outside. It's made of it's a fibrocartilaginous ring. It's 50 to 60% collagen. So I always think of the nucleus pulposus of the disc actually as like a jelly donut. So the inside of the donut is the nucleus pulposus, and the outside of the dough is I refer to as the annulus fibrosus, which surrounds that jelly inside of the donut. Okay, so very important to know. Please star this. The next point right here, that the disc is very avascular and aneural. What does avascular and aneural mean to you guys? So no blood, very poor blood supply, very poor nerve supply. So very good. So healing of this damaged disc, thank you, Evelyn. So healing of this disc is very unpredictable. It's not promising. So somebody with a herniated disc may get some relief from therapy, but then they do a motion that is out of the ordinary, or they do a motion that kind of pushes that nucleus pulposus back to where it was, that caused the herniated disc, and then all of a sudden they get their symptoms back again. It's not something that you directly go to surgery about and fix with surgery. Most of the treatments for herniated nucleus pulposus are going to be conservative treatment with anti-inflammatories, physical therapy, modification activities of the patient to make sure that they don't go back to those positions that caused this. But we're going to talk about specifically herniated discs in a couple of slides down. But it's very important for you to remember that it's very poor blood supply and it's very aneural, which makes it very kind of unpredictable with the healing process for a herniated disc. Then we're going to talk, now we're going to talk a little bit about the anterior motion segment. So what is helping the spine in the front? What is kind of keeping it from going into those extreme amounts of movement? So in the red, you see here, we have the anterior longitudinal ligament. For all of these ligaments that I'm going to be talking about, you have to know what they do and you have to know what they limit. Okay, you have to know the location of the ligaments. So I color-coded them for you. We have the anterior longitudinal ligament. I'm going to turn on my video because I have a picture, actually a model of the spine here. Can you see the video there? Yes? No? Maybe so? Okay, perfect. So anterior longitudinal ligament is going to be the red portion that you see there. So it's going to be in the front. So my hand here is the anterior longitudinal ligament. Okay, it's very dense, it's very powerful. It attaches to the anterior discs and each vertebral body. And what it limits, it's hyperextension. So my patient is going to go into this extension movement, and my anterior longitudinal ligament is going to say, hey, you're going too far, you need to slow it down or go ahead and hurt me. So this is my anterior longitudinal ligament. I sit right here. My patient is going, now I'm pushing it into extension, spinal extension, and my anterior longitudinal ligament is going to kick in and say, you're going too far, come back to where you're supposed to be. Okay, it also limits forward movement of the vertebrae relative to each other. So as it's going back, it's preventing each vertebral body from kind of migrating anteriorly because it's like a stop sign. It's placing a stop right here so that all of the vertebral bodies can stay in place. Was that clear to everybody? Okay, so before we continue, I want to go ahead and tell you, before you leave class today, I want you to post a question regarding any of the content I cover in the chat. So that's going to be your ticket out of class today. I will copy and paste those questions into a discussion forum, answer them so that everybody can see. So please make sure that you're thinking of what you're going to be writing or asking me at the end of the lecture. All right, and you're just going to post it on there and I'll have your answer for it. You'll have your answer tomorrow. All right, so moving along, we have the posterior longitudinal ligament, which travels inside of the spinal canal. So I'm going to kind of stick my pen in where it should be. So it's going to be in there. Okay, it travels inside that spinal canal. So it travels inside here. I don't know if you can really see that it travels right here. It connects the rim. It connects to the rim of the vertebral bodies and the center of the discs. Okay, so the posterolateral aspect of the segment is really not covered by those ligaments. In this specific model, we have a posterolateral disc herniation. And the reason why this is the most common form of herniation is because this portion is going to be covered by the anterior longitudinal ligament. The inside portion is to be covered by the posterior longitudinal ligament, but there's really nothing kind of helping this area, the lateral aspects out, which is why this discs kind of have only one way out. It can happen that the patient has an anterior lateral disc herniation, but the most common are going to be posterior lateral because there's no ligament kind of protecting this lateral area. Okay, so this ligament, let's continue here. What I just said is the next bullet point. The posterior aspect of the segment of the spine is really not covered by anything, so it's a common site for disc protrusion, as you see here in the model that I'm showing. This is going to offer resistance to flexion. So if my patient is going forward into flexion, the posterior longitudinal ligament is going to say, hey, you're going too far, you need to come right back, or you're going to go ahead and you're going to damage me or hurt me or tear me. So that's what that resists. Is that clear, or do you need me to repeat it? I'm going to stop the video. All right, I assume it's clear. Okay, perfect. Then we have our posterior motion segment, which consists of bone tissue. So bone tissue that is in the pedicles is very hard, which provides good protection. So that's in the posterior segment of the spine, that's what kind of protects. One of the things that protects. We're going to be covering muscles, other ligaments that also provide a protection to the spine. Muscle attachments at the spinous and the transverse processes also provide stability for the spine. Articulation between vertebrae occurs at the superior and the inferior facets, which also provides stability. So you see your spine, the spine fits perfectly like a puzzle. It supports each other. So they support, the bottom one supports the top one supports the bottom. So that's what we want, that's what I want to make clear for you, that there's support from all different segments. These facets are oriented at different angles related to the spinal section to account for functional differences. What that means is this picture in the top right-hand corner, you see the cervical spine. The facets are pointed at a different direction to allow for that free movement of the cervical spine. Since our cervical spine is the one that moves the most, it requires that angulation of the 45 degrees in the facets. Now the thoracic, it's a 60-degree angulation. Thoracic moves along with the cervical. There's really no isolating movement of thoracic spine. And then we have our 90-degree angulation of the facets, which we see in the lumbar spine. And the lumbar really doesn't have that much movement, as we're going to see in a couple of upcoming slides. Now, going back to my video here, we're going to talk about the ligamentum flavum. The ligamentum flavum is going to be the one in orange. I hope that's orange. It spans the laminae. It spans in between the laminae. So within the spinal canal, in between each. So I would show it better when you come into to campus, when we do a little bit of a lab. But I really can't show it here because the spinal cord is in the way. I'm not going to pull the spinal cord out. So it's very elastic. So it helps in extension following flexion of the trunk. So when that patient goes ahead and does a little bit of flexion of the trunk, the ligamentum flavum that's in between is going to go ahead and act like a rubber to kind of spring the patient back into that neutral position, into that upright position. So with that said, it is very elastic because it needs to help in that extension following the patient going into flexion. It is under contention, so I would think of it as a rubber band because it's always under that constant tension. My patient is going to go into flexion, and the ligamentum flavum is going to help with springing it back into place, into that neutral upright posture. Then we have our supraspinous and our interspinous ligaments. So these are all with the spinous processes. So supraspinous, it says it in the name, is going to be above the spinous processes. And the interspinous is going to be between the spinous processes. So just remember it like that. Supra, above, spanning the spinous processes. And then we have the inter, are between here where I'm putting my finger. That's where the interspinous ligaments are going to be located. And these are going to resist, they're going to resist shear and forward bending of the spine. So forces, when we talk about shear forces, we're talking about those forces that mean the sliding of one vertebrae with respect to another. So they're going to avoid the vertebrae sliding too much on top of each other, on top of one another. So that's what resisting those shear forces are. Okay, was that clear? Okay. All right, so the motions of the spinal cord, you guys should know this. I know you know this. Flexion and extension in the sagittal plane. It's very important to know that with flexion, the anterior portion of the body approximate and the spinous processes are going to separate. I'm going to demonstrate that for you with this model of the spine that I have here. And then with extension, the anterior portion of the body separate and the spinous processes approximate. We also have side bending, which is in the frontal plane, and we have rotation, which is in the transverse plane. It's when superior portion rotate, hold on one second. When superior portion rotate in different directions regarding the lower portion. Yes, Juan. For the shear forces? Yes, yes, correct. So let me turn on, you're welcome. Let me turn on the video again. So what this statement is referring to is with flexion of the spine. So my patient is very right here. With flexion, I'm trying to flex right here. The anterior portion of the bodies are going to come together. So everything in the front is going to come together, obviously, because we're going into that flex position. And the spinous processes are going to separate. So everything in the back is going to kind of pull apart because we're going into flexion. Now, with extension, the anterior portion of the bodies are going to separate. So everything in the front is going to kind of separate a little bit, while the posterior segments, which are the spinous processes, are going to come together. So they're going to get a little bit crowded in the back. Okay, everybody good with that? Okay. So spinal movement, collectively, we have a large amount of range of motion if we look at the spine from top to bottom. Just repeating the motions of the spine, we have flexion extension, also referred to as forward and back bend. We have left and right rotation, and we have left and right lateral flexion as well. Looking at this chart, the next slide, there's some regional range of motion in the spine. This kind of tells you a little bit about how much motion is in each of the units. The two bullet points here are the most important. Atlas C1 and C2 take up for 50% of the rotation in cervical spine. So they do a lot. Thoracic region is really restricted because obviously it's attached to the region above it, the region below it. So it kind of just goes along with the rest of the spine. And then it is also has a connection to the ribs, which kind of limits and restricts the motion as well. So I don't need you to remember this chart. I just need you to know the bullet points that are on the side. I'm not going to be asking percentages of the range of motion in each of the segments of the spine. So we also have biomechanical influences on postural alignment. So we know, the curves of the spine. Gravity is going to always place a stress on the structures that are responsible for maintaining that body as upright as possible. So we're always fighting gravity. There's always going to be a continual challenge to stability and to keeping efficient movement in our patient. So it's just important to remember that please know the curves of the spine. The cervical, we have lordosis. We have our thoracic is a kyphosis, a kyphotic curve. Lumbar, we have a lordosis. Then we have sacral kyphosis, and obviously your coccyx is your tailbone. But just know that those curves in each of the segments, and also know that gravity is always taking a toll upon our posture. So everything that is working in our spine, whether it be ligaments, the bones, the muscles, is always constantly fighting against gravity to keep us upright as possible. And you know that something that can go wrong with a certain portion of it, whether it be weakness in the muscles, whether it be degeneration with osteoarthritis, can have an effect and will have an effect on our posture, because that's just one less mechanism that we have to fight against gravity and keep us in optimal posture. All right, so I'll quiz you a little bit here. So you can just answer on the chat, or you can turn on your mic. I am the segment of the spine that has the least amount of movement. Who am I? All right, thoracic, good. I am so dense and powerful, I prevent hyperextension. Who am I? The anterior longitudinal ligament. Yep, good. All right, so we both have lordotic curves, yet we are such different segments. Who are we? Cervical and lumbar. Yep, lumbar, cervical. All right, so we both span the spinous fasces and resist shear and forward bending of the spine. Who are we? Supra and infraspinous, and yep, interspinous and supraspinous ligaments. Good one. I am the most mobile segment of the spine. Who am I? Cervical. Good. All right, let me just see Jordan. Jordan, can you hear me now or no? Still can't hear me. Let me just restart the computer. All right, I'm a gel-like mass in the center of a disc. Who am I? Nucleus pulsus. Good. All right. I am 50 to 60% collagen. Who am I? Again, you don't have to know this for a test, but just as a fact, annulus fibrosis. Good. I travel inside the spinal canal and connect to the rims of vertebral bodies. I also assist flexion. Who am I? Yep, the posterior longitudinal ligament. Good. And then finally, I connect adjacent vertebral arches, and I'm very elastic. I help in extension following flexion of the trunk. Some say I'm a little tense. Who am I? So that will be your, anybody want to try something else? Ligamentum flavum is the one that is like a rubber band that kind of helps bring the patient back into upright posture after going into that flex position. Good. Overall, we got most of them right. All right, moving on. When we're talking about stability, if our patient lacks stability, if our patient line of gravity does not fall within that base of support, the patient is going to fall, right? So we want to have a stable core in order for our patient to be stable. So as long as that line of gravity from the center of mass falls within the base of support, a structure is stable. So like I said before, when the center of gravity kind of falls outside that base of support, either the patient's going to, or some force must act to keep that structure upright. This is kind of the same principle that we're using to kind of stabilize and to strengthen the core or the spine. Spinal stability is held by passive structures and inert structures. The passive structures, it's important to know what's in the parentheses. So my passive structures is what I just talked about. We talked about bones and the pedicles. We talked about the ligaments. We talked about the vertebral bodies kind of stacking on top of each other to provide that support to fit that perfect puzzle piece of the vertebral column. And then we're going to talk a little bit more now about the active structures. So now we're talking about muscles. We're talking about also neural control. So the nerves also play a role in maintaining stability. So we're going to dig a little deeper now into the active structures, which are muscles, because they move, so they're active. Okay, so we have our, we're going to talk about it in segments. So we're going to talk about the top segment, the bottom, and the front and the back. All right, so we're going to start with the back, the posterior muscle support. We have our erector spinae, we have our spinalis. These are deep posterior muscles that provide stability to our spine. They primarily focus on producing extension, medial and lateral flexion. These are very versatile muscles that can generate rapid force, yet are fatigue resistant. So what does it mean to be fatigue resistant? fatigue resistance? What do you guys think? Anybody have any idea? Exactly. So they don't tire easily. So yes, has good resistance. They don't tire easily. These are slow twitch muscle fibers that focus on sustained smaller movements. So basically, they work 24/7 unless we're resting. They work a lot to provide that postural support. Yes, postural muscles, exactly, Frank. So these fatigue-resistant muscles can function at very high levels for an extended amount of hours and even into the night. Yes, primary type 1 muscle fibers. Yes. So good. I like where you were going with that, Billy, Juan, and Frank. Awesome. Anaerobic, yes. Any questions regarding that? What I need you to know is that, so let me go back to this slide because it's very important for you to be clear on what I need you to know as far as these muscles in the back, such as rectus spinae, the semispinalis, that they are focused on maintaining posture. So therefore, they fatigue they don't fatigue easily because they're constantly working, kind of keep us in that upright posture. Once again, if you have a question regarding that, just save it for post it at the end. If you're asking now, up to you. Then we're talking about the muscles. So now we're going kind of specific to certain type of muscles that we're going to be activating or strengthening during our stabilization and strengthening exercises when we're in lab. The multifidus is able to control movements of the spinal segments as well as to increase stiffness in the spine. Okay, the multifidus also works with the erector spinae. They are kind of enclosed by the posterior and the middle layers of the lumbo-dorsal fascia. So a muscle contraction will increase the tension on that fascia, which will also help in stabilizing the spine. So you see how all of them kind of work together to provide that physiological back brace. It's kind of like a back brace that is on our backs. When we talk about the abdominals, also that's part of the brace. Okay, and we're going to talk about some muscles that are in the upper portion and lower portion as well. So in patients with low back impairment, the fibers of the multifidus kind of atrophy quicker at the spinal segment that's affected. So example of that would be my patient that has a lumbar L4, L5 disc herniation. The multifidus at L4, L5 is going to be the first one to atrophy because it is the area that is affected by the pathology that the patient is presenting with. Is that clear? Okay. Okay, then we're going to the front. Now we're going to the anterior segment, and we have our abdominal muscles. So what is the muscle for letter A? What muscle is that? Rectus abdominis, yep. Okay, what's B? B is going to be our transverse abdominis. C is going to be which oblique? Internal oblique, and then D is going to be your external oblique. Good. So this is the brace, the part of the brace that's in the front of our bodies. So the transverse abdominis is going to be your deepest muscle, deepest of the abdominal muscles. and it responds very well to postural perturbations. So it kind of helps you maintain that upright posture. It is one of the muscles that we're going to focus on engaging when we do a lot of the exercises, dependent upon the patient's pathology. Only the transverse abdominis is active in isometric trunk flexion and extension. So that's how powerful it is. The other abdominals have decreased activity with resisted extension. Okay, the transverse abdominis also responds with anticipatory activity. With rapid leg movements, you're also activating your transverse abdominis. It kicks in before any other abdominals. So this is our go-to muscle when we're trying to stabilize and strengthen the spine. We're going to learn how to activate the transverse abdominis during lab. The transverse abdominis also coordinates with respiration when the patient or you are having rapid arm leg movements. You have coordinated leg with the perineum and the pelvic floor muscles. So I want you to think of the trunk as a bucket. So you know the bucket has the front of the bucket, the back part of the bucket, the top, and then we have the bottom. So at the front of the bucket, we have our abdominals that are protecting that water from coming out of that bucket. In the back, I've already covered, we have the paraspinals that are protecting that spine in the back portion. At the bottom, we have our perineum and we have our pelvic floor muscles that are protecting that water from coming out. And then we have at the top, we're going to talk about in the next couple slides, we have our diaphragm, we have our intercostals, which also provide stability to the spinal cord. Okay, that takes us to the next slide, where we talk about intra-abdominal pressure. This intra-abdominal pressure, like a balloon, expand the spine and therefore reducing the compressive load that is being put on the spine. So it kind of helps out the erector by reducing the activity that is needed by the erector spinae. So they kind of all work in conjunction, which is why I gave you the illustration of having a bucket and trying to protect the water inside the bucket. Just replace the water with the spine, So that's what everything around the spine kind of does to protect it. Then we have internal and external oblique muscles, and also the transverse abdominis that attach to that thoracolumbar fascia, which covers the posterior region of the trunk. When the abdominals contract, specific abdominals, it just adds increased support for the low back. Do you see how this would create a sort of brace for your spine? Yes. Okay. Did anybody need me to repeat the illustration that I use for the bucket? Or you got it? Sure. So that intra-abdominal pressure kind of creates like a balloon effect to help expand the spine and reduce any compression that is being put upon the spine. Also, with that intra-abdominal pressure, it kind of helps to stabilize and reduces some of the work that the paraspinals have to do. This, we're talking about just stabilization of the spine. It could be like when you're going to pick up a heavy box from the floor. So that pressure kind of also helps and provides much needed support. Did that clear it up, Frank? Okay. So additional muscles that contribute to trunk flexion, what muscles are these right here? All right, iliopsoas, and then this one right here. Quadratus lumborum, good, good. All these muscles kind of have an effect on support our spine. Good, now we're gonna talk a little bit about neurological control and its influence on stability. So the muscles of the neck and the trunk are, as you know, activated and controlled by the nervous system. So if somebody has some condition or damage to their nervous system, this is going to obviously take an effect on posture. think of somebody with a spinal cord injury or a traumatic that caused some nerve entrapment or some nerve compression. Obviously, it's going to have an effect on the muscles that are innervated by that muscle, by that nerve root. So it's important to know that neurological control has a definite influence on stability of the spine. Nervous system really coordinates the response of the muscles to expected and unexpected forces. So even though we don't think about it, our nerves are also controlling any type of force, whether we're expecting it or not. At the time, by the right amount of modulating stiffness and movement to match the various imposed forces. So very important to know that it has a very big influence on stability when the patient's nervous system is affected. A little bit more about the effects of breathing on posture and stability. Inspiration and thoracic spine extension are going to elevate your rib cage and to assist with posture. So it's also very important to teach breathing exercises to the patients to promote optimal posture. The intercostal muscles also function as postural muscles to stabilize and to move those ribs. Those internal intercostals and the external intercostals also assist with stabilization. The transverse abdominis, or TRA, when you see TRA, this is transverse abdominis. You might see it in the lab handout, you might see it in this presentation as well. So the TRA and diaphragm also provide stability during rotative limb movements, as we talked about when we were talking about stability before. Any questions so far? No questions. Okay. So this is just a survey that was conducted by the American Osteopathic Association. I don't expect you to know the percentages here, but it's just the most common is that have pain, that patients complain of pain due to poor posture. So we have 33% at the wrist, we have 53% at the neck because he has that forward head, 38% at the shoulder because we're going into that rounded shoulder posture, and 63% is low back. So you see the highest is going to be our low back. So now we're getting into some of the conditions, some of the faulty postures that patients seem to take due to impairments that are going on or due to poor postural habits. So talking about postural pain syndrome versus postural dysfunction. Our step one with these two conditions is going to be postural pain syndrome. This is going to be pain that happens due to mechanical stress when a person maintains a faulty posture. So this is the patient that worked as a data entry clerk at a computer 8 hours a day, 5 days a week, and they have this poor posture. So the patient is going to have pain during those times. So the patient is going to have those faulty postures during the work time. As soon as they leave work, they go back to their regular posture and the pain is relieved because they're no longer in that faulty posture. There's really no abnormality in muscle length or muscle strength until that posture continues. Obviously, muscles are going to get shortened, muscles are going to get lengthened and weak. So if the posture continues, then postural imbalances are going to occur. Okay, everybody understood that? Okay. Now we go into postural dysfunction. So postural dysfunction is that patient that has continued that faulty posture. Because of that faulty posture, he does it at work, he does it at home when he's on the computer. So now there's adaptive shortening. So muscles have gotten short, some muscles have gotten weak. The cause is obviously going to be that poor postural habits, and contractures also can be due to previous injuries or surgeries, but it's mostly due to poor postural habits. So it's that patient that has that postural pain syndrome They never corrected that poor posture. So now there's a dysfunction because the muscles are affected and the joints are affected. So stress on the shortened structures can cause pain. Fatigue, the muscles that are elongated are going to cause pain. Muscle imbalances are going to lead to overuse symptoms. So the patient is going to do compensations because some muscles are weakened, some muscles are lengthened. So now they're going to go into this postural dysfunction. Faulty postures in one region of the spine can and will most likely affect other regions of the spine. So I put this slide here because basically it starts as postural pain syndrome, and then it can domino effect back into postural dysfunction if it doesn't correct the faulty postures. The last bullet point here, what that means is that, say my patient starts with forward head because they're looking at the computer all day. So now it's going to go into the thoracic. They're going to start getting the rounded shoulders. Their kyphosis is going to increase because of that posture. And then eventually it will go down all to the lumbar spine. So it's a chain effect. If we don't catch it early, it's going to be harder for us to get that patient back to as optimal posture as we can. Would this be an effect of the Wolff's Law? How so?
Since it's the postural dysfunction says it's adaptive shortening and muscle weakening has occurred. Maybe due to that pain, the muscle adapts to the situation of the shortening of the muscle.
Yeah, I mean, you can look at it that way, like the putting the stress and demands on areas where it shouldn't be stressed or in those positions. Yeah, definitely, it will adapt to the posture that you're putting them in. So yeah, that could be a good correlation to Wolff's Law.
Okay, thank you.
Mm-hmm. All right, so this is where it gets a little bit tricky for students to kind of remember the postures and what is happening not at each segment, but what is happening in the front and what is happening in the back. So we have about 4 or 5 postures that we talk about and analyze as to what is going to be affected when it comes to ligaments, when it comes to muscles, when it comes to the joints in the spine. So these next couple of slides are very, very, very important. We start with forward head posture. This is the common cause of tension headaches. It's been known. The position of the joint in this patient, the upper cervical spine, as you see here, is going into extension, while the lower cervical spine is going to go into a little bit of flexion. So this is forward head posture that I'm talking about when I was talking about the postural dysfunction. So this can be caused due to poor sitting posture, being on your cell phone all day. They refer to it as text neck. In the last couple of years, it's been referred to as text neck because everybody's on their phones and kind of shifting their head into a forward position. It can be due to optional requirements. So the same patient that I was talking about in the example before, this patient can be on the computer all day and just not know that they're doing this. And then eventually, because they've been working at this place for years and years, they go to therapy for pain that they're having in their neck, and it can be just originating from the poor posture that they've been holding for years and years. So we're going to talk about these. This is my son. I tried to have him do some of the postures. It's very difficult to have somebody perform a posture that is not the normal posture. So as you see here, it kind of gives you a little bit of a better illustration of forward head posture. So how are we going to break posture down? Possible sources of pain. Now that you know the locations and what the ligaments do, the anterior longitudinal ligament can be strained in the upper cervical spine. The posterior longitudinal ligament, the ligamentum flavum, The nuchal ligaments can be strained in the lower cervical spine. So you kind of have to take the posture and know exactly where it is these ligaments are located. And with the posture that you're looking at, you can tell what is going to be stressed and what is not, what is going to be lengthened or weakened. So we're going to talk ligaments, we're going to talk joints, and we're going to talk muscles. So the joints that can be affected, the facet joints can come closer together in the upper cervical spine. And there can be narrowing of the intervertebral foramen in the upper cervical spine that can lead to lateral stenosis. Okay, there can be possible disc problems, lower cervical spine. And then for the muscles are going to get, there's going to be a lot of tension in the muscles. There's going to be fatigue. So specifically talking about muscles that can get shortened are the levator scapula, your upper trap can get shortened, suboccipital muscles, and all the extensors can get shortened. The scalenes, possibly the sternocleidomastoid, but not necessarily. And once again, these cannot, doesn't necessarily all happen together. It can be just a few muscles that are shortened, a few muscles that are lengthened, but typically kind of, if the spine is in flexion, the muscles in the front are going to tighten while the muscles in the back are going to get weakened. So that's how we look at it. And basically how the patient presents is how we're going to gear our treatment. So obviously we would stretch the muscles that are tightened and we would strengthen the muscles that are weakened in the back if we're just at the flexion component of the cervical spine. Then the muscles that are lengthened are the infrahyoid, suprahyoid, the longus colli, longus capitis, and sternocleidomastoid. So please make sure that you study these slides. It's easier to see if you have a diagram. So I have some diagrams that I kind of put together for the upcoming postures. Cervical is pretty simple to kind of see what is going to be shortened and what is going to be lengthened. And we're moving on to thoracic kyphosis and rounded shoulders. So the position of the spine is going to be, the thoracic spine is going to be flexion. The scapula are going to be protracted. Okay, so you see here, there's rounded shoulders. Scapula is going to be in protracted direction. Thoracic spine, some slight flexion is there. The causes can be increased kyphosis, often seen with forward head. Like I told you, it's a change. So if the patient is having poor postural habits and postures in the cervical, eventually the patient is going to go into this excessive kyphosis and excessive rounded shoulders. Okay, so this is just a little bit of an illustration with a thoracic kyphosis with the rounded shoulders. So what do you think from looking at this picture here before we go on to the next slide? What is going to be shortened? What muscles are going to be shortened here? Just from looking at this picture. Okay, perfect. Pec minor, pec major. What else? How about abs? Are the abs going to be shortened? Yes. So yes, upper abdominals, pec major, minor, you guys said. Serratus anterior, Frank said, absolutely going to be shortened. Now, what muscles are going to be lengthened in this area here? Rhomboids, good. Middle trap, and the extensors, good. Lats, maybe lats, yeah. All right, so into the slide here. So some of you said the muscles already. I know you have the PowerPoint, so you're probably looking at it, but it kind of helps to kind of put it together with a picture rather than seeing them on a list like you see here. So possible sources of pain here, the patient has stress to the posterior longitudinal ligaments, the ligamentum flavum, the supraspinal and interspinal ligaments may also be put on a stretch because of that poor posture. Muscle, there's going to be always muscle tension and fatigue, but specifically talking about the muscles that you guys talked about, all the muscles in the front. So let's go back to the slide. All the muscles here, upper abdominals, pec major, minor, shoulder internal rotators. You see his shoulders and internal rotations, which means that the internal rotators are going to get shortened. Serratus anterior, long muscles in the back. We have lengthened of the upper trapezius. We have rhomboids lengthened, the thoracic extensors, erector spinae. All of those are going to get lengthened. With lengthened muscles comes a lot of weakness because these muscles are overstretched. So now they're becoming very. So what would our treatment be for our patient like this? What can we do from what you learned already? Stretch the anterior muscles and strengthen the posterior muscles. Good. So that's the thought process that I want you to take with all these faulty postures. Then we have our lumbar lordotic posture. So joint positions, the lumbar spine, as you see here, is in hyperextension. Okay, so, or excessive lordosis. This is a very, very increased lordosis that you see here. The pelvis is going to be in an anterior pelvic tilt, as you see there. And the hips are going to be flexed because that pelvis is going into the anterior pelvic tilt, which means that you're flexing your hips. Okay, so this can be due to faulty posture, obesity. If somebody carries a heavy load, a beer belly in the front, is going to pull them down, push them into that anterior pelvic tilt, which can have them take this posture, this faulty posture, this lumbar lordotic posture. So another reason, obviously, pregnancy. Obviously, they're carrying that excess weight in the front, so that's going to pull them into that anterior pelvic tilt and cause that increased lordosis of the spine. Also, weakness in the abs is going to pull down and into that anterior pelvic tilt, increasing that lordosis. So not a very good picture of an anterior pelvic tilt here. He wasn't able to do it, but what do you think here is going to be shortened if he was more into an excessive anterior pelvic tilt? So what muscles are coming together or shortening? Good. So the quadratus. All the lumbar extensors are going to be shortened. The erector spinae, the hip flexors, because the hip is in flexion when we're doing anterior pelvic tilt, those are going to be shortened and tight, so we have to stretch. The TFL and sartorius, not so much, but they may be tight. And then the rectus, maybe. How about lengthened? What is going to be lengthened and weak here? So as you see him coming into that, exactly, as you see him coming into that anterior pelvic here, this right here is going to get longer because the hip is going to be in flexion. So yes, abdominals, the hamstrings may be lengthened, and possibly gluteus maximus can be lengthened as well because the hip is going into fin. Hamstrings, yes, Frank. So let's talk about it here. So possible sources of pain in a patient with a continuous lumbar lordotic posture can be stress on the anterior longitudinal ligament. The joint that can be affected can be the fist joints due to that compression. Narrowing also of the intervertebral foramen. That's called lateral stenosis, and we'll talk about that condition later on in the presentation. Like I've been saying, muscle tension fatigue is going to be present for all of these postures because it's not normal. The muscle impairments that you guys mentioned already, the shortened muscles, everything that's going to get tight is going to be in the back. So lumbar extensors, which includes your erector spinae and all the ones listed here. Hip flexors, the hip is going to be in flexion, meaning that the hip flexors are going to be shortened. The TFL and the sartorius may be, but not necessarily. Lengthened muscles are going to be everything in the front, the abdominals, the hamstring, possibly the gluteus max because of the hip being in flexion. That will lengthen the gluteus max. So I'm going to share with you now a file that I put together. Let's see if I have it here. And I'll post this for you. So I kind of like to give you an illustration of what's happening here. So short is this color, muscles that are long are going to be this color, and we're going into an anterior pelvic tilt, which we're going in this direction here. So it just kind of shows you exactly what is going to be shortened. The lumbar extensors, like I just said, the hip flexors, because we're going into hip flexion, are going to be shortened. Sometimes this motion into the anterior pelvic tilt shortens the TFL and sartorius as well. And then the long muscles are going to be lengthening of the abdominals right here. Possibly the glute max is going to be lengthened due to that hip being in flexion, and the hamstrings are going to be lengthened as well when you go that excessive anterior pelvic tilt. Okay, any questions about this? Okay. All right, I'll post these online for you guys to have. Hopefully it takes me back to, nope, it's not going to take me back to the same slide. Let's see. Okay. Okay, then we move on to flat low back posture. So with the lumbar lordotic posture, we were talking about an anterior pelvic tilt. Now with the flat low back posture, we're talking about a posterior pelvic tilt. So this patient completely flat back. Okay, there's a decrease in lordosis. There's going to be lumbar flexion, posterior pelvic tilt, which means that the hip is no longer in flexion, now it's in extension. So a cause of this can be having sitting for X amount of hours a day for several days a week for years. That sitting in that slump posture can eventually lead to flat low back posture. Also, overtraining and flexion may cause this because you're always going into that posterior pelvic tilt. So it's just another of the causes. Okay, so we have here flat back. It's not really a good picture of a flat back, but what are you guys going to be shortened here in this flat back posture? All right, let's go to the next slide. So possible sources of pain on the ligaments, there's going to be stress on the posterior longitudinal ligament, the ligamentum flavum, the interspinal and supinous ligaments may be stressed. Possible stress on the joints, stress on the disc, secondary to posture, due to a decrease in shock absorption because there's a decrease in the lordosis. The muscles that are going to be shortened are the abdominals, the hamstrings, and the gluteus maximus. And the muscles that are going to be lengthened are going to be the lumbar extensors, including all those listed here. The hip flexors and the TFL and the sartorius may be lengthened as well. Okay, so let's just share this picture here. You guys can hear me okay, right? So I want to make sure that, because I didn't hear anything back from anybody. Okay, perfect. Okay, so our flat low back posture here. Once again, so this patient is going into a posterior pelvic tilt. So this is going to be completely flat. There's not going to be that normal lordosis that we want to see with our patients. So that posterior pelvic tilt is going to go ahead and shorten these abdominals because they're going up and kind of going into that posterior tilt. So shorten abdominals. The glute maximus is coming closer together, which is shortening it. Okay, and then the hamstrings with the posterior pelvic tilt are shortening as well, which are going to get tight. This is going to lengthen the hip flexors. When that posterior pelvic tilt is happening, the hip flexors are stretching and becoming weaker and longer. Sometimes this posterior pelvic tilt will also lengthen the TFL and the sartorius, and the lumbar extensors are going to get lengthened as well because of the mechanics of the posterior pelvic tilt. Do these pictures help or not? Okay, perfect. All right, so I'll be posting them after the lecture today. Bear with me, guys, because it kicks me out to the beginning of the PowerPoint, and I have to go back to the slide where I was at. Okay. Okay, so this is probably the most complicated posture of all. It's called slouched. It's also called referred to as sway back posture or relaxed posture. Guys, super relaxed as you see here. Possible joint positions, and this is not necessarily that all of the joints are going to be in the same exact position for everybody who has a sway back posture. So it's very important to separate anterior pelvic tilt and posterior pelvic tilt from this posture. What happens with the pelvis is that it displaces anteriorly. So it doesn't go forward, it doesn't go back. The pelvis as a whole just kind of shifts forward. So as you see here, this is kind of the normal place where the patient should be, the midline. And then the pelvis just kind of shifts anteriorly. So now the pelvis is sitting right here. The lateral malleolus is sitting behind, and the humeral head is sitting behind the pelvis. So the alignment is completely thrown off because that pelvis is displaced forward. Okay, there's also a posterior shift of the upper trunk. Hips are going to be in extension. So in other words, increased lordosis secondary to anterior pelvic displacement. So there might be a little bit of a lordosis because that pelvis shifted forward. But what I don't want you to have in mind when you're talking about sway back is a pelvic tilt, because it's not tilting, it's just shifting forward. Okay, there's also increased kyphosis, second posterior shift of the thorax, like I mentioned before, and it could be accompanied by a forward head. So there's a lot going on in this faulty posture. So causes can be due to passive posture or a poorly designed exercise program. So somebody that's doing exercises continuously for X amount of years and they're just having very bad form, this can happen to them. My son couldn't do this posture, so there's no picture here for that. But let's look at this here, and then we'll look at the illustration that I have for you. So possible sources for pain can be so many because there's so much going on. There can be stress to the iliofemoral ligaments, stress to the anterior longitudinal ligaments in the lumbar spine. There can be lateral stenosis in the lumbar spine, approximation of the facet points in the lumbar spine. Muscle tension and fatigue is going to be known for all of these. Okay, the potential muscles or muscle impairments in the lumbar spine and the hip. So the muscles that are going to get tight are going to be the lumbar extensors, including all of these listed here, the erector spinatus, the rotators, the multifida, intercervicalis, and the interspinalis are all going to get shortened. The hamstrings, the gluteus max is going to get shortened, and the lengthened muscles are going to be your lower abdominals, your hip flexors, and your TFL and your sartorius. Let me go ahead and share this one here. Okay. All right, so as you see here, there's really no pelvic tilt. So there's no arrow that are causing this to go into an anterior or a posterior. There might be a slight anterior a slight increase in that lordosis, but it's not due to a tilt, it's due to a shift. So you see my arrow here pushing this forward anteriorly. You see the forward head going forward, and you see the kyphosis increase as well. So you're going to be, the lower abs are going to be lengthened due to this anterior shift and due to this kyphosis increase. The hip flexors are going to be lengthened because of the shift as well. TFL sartorius may be lengthened. With this shift, this is going to shorten the hamstrings. It's going to put the hip in extension. It's going to shorten the glute max. It's going to shorten the lumbar extensors. due to that lordosis increase. So with that anterior shift of that pelvis, it's an increase. This is one that takes a little bit for you to kind of understand. It's easier for me to explain it in the lab. So I'm going to go ahead and just leave this here, let it marinate a little bit. I'll provide this. If you don't understand why things are getting tight, why things are getting weak or long, just ask me, and I'm going to explain this one in lab because it's a little bit more difficult to understand. Any questions? You guys are super quiet today. It's not Monday, guys. Gotta save the question discussion. Okay, that's a good excuse. All right, and our final postural deviation that we're going to cover before we get into the conditions that we're going to be covering is a lateral pelvic tilt. So lateral pelvic tilt is any lower extremity inequality is obviously going to have an effect on the pelvis that will affect the spinal column because there's not a level that we should have. The pelvis is not level, so one side is going to be lower than the other, which will throw everything off. Okay, so frontal plane deviations may also be seen with faulty postural habits, such as the people that usually stand with a pelvic drop on one side, as seen in relaxed postures. This picture here that you see, where she's holding the baby on one side, obviously that side is going to be lower than the higher side. If she's doing this every day of her life for X amount of minutes a day, this can have an effect on some of the muscles. Some of the muscles on one side will get tight. The muscles on the other side will get weak. But that's if she continues with this faulty posture. So as with all the postures that we talked about, it's very important to know that if patient holds a faulty posture for 1 or 2 times, it's not obviously going to have an effect, such a big effect, but it's if we continuously use these faulty postures, then we're going to have an effect on the structures of the spine. Okay, so this is your lateral pelvic tilt posture. And what we see here is lateral flexion of the spine on the high side. So this is our high side, this is our low side, and we're talking about low and high. So this is going to be, is going to flex this way to try to bring this side up and leveled, right? There's going to be hip adduction on the high side, so this kind of goes closer, okay, which will in turn tighten those adductors because you're just getting closer to try to maintain that as level as possible. There's going to be hip abduction on the low side, so this side is going to, the hip is going to go into abduction to try to maintain that as optimal posture as possible. So with this hip going into abduction, what's going to get tight on this leg? What do you think is going to get tight on this side? And what do you think is going to get tight on this side? If this side, the side is going into adduction, and this side is going into abduction, what muscles or muscle groups are going to get tight? Quadratus. Okay, yeah, quadratus will get tight here. But specifically talking about the adductors and the abductors, if this side, the high side, is going to continuously be in adduction, that means that the adductors are going to be tight, which means that the abductors on this side are going to get lengthened and weak. And then now we're talking about the low side. If this side is going to be in hip abduction to try to keep it as level as possible, this is all happening stand space of gait. This does not necessarily have to happen when the patient is just simply standing. So on the low side, the position of the joint is going to be hip abduction. So with that hip abduction, it's going to shorten the hip abductors, and it's going to lengthen and weaken the hip adductors on the low side. So the causes, you'll see it better when I show you the illustration. So the causes can be structural or functional deviations at the hip, Knee or foot. Unilateral pes planus, that means when you have a flat foot, or a leg length discrepancy can also cause this lateral pelvic tilt posture. As you see here, the hip is dropping on this side. He's leaning over. That's the trunk flexion. This side is going to be an abduction, while this side is an adduction to try to keep it as level as possible. So it kind of gives you a little bit of a better illustration there. Now let's talk about this, and then I'll show my final illustration for this. So possible sources of pain. There can be shear stress on the elevated side at the hip, compression stress on the low side. Sacroiliac joint pain can also be caused due to this lateral pelvic tilt posture. Lateral stenosis on the elevated side in the spine because you're trying to flex to try to bring the pelvis up on the low side. Facet compression on the elevated side as well. Muscle fatigue and spasms due to the asymmetric loading. You're putting obviously more work on one side than the other. You're trying to work that high side to get the low side to come up as much as possible. So obviously there's going to be a discrepancy between how the muscles are working on both sides. Potential imbalances. On the high side, you're going to have tightness of the hip adductors, the quadratus lumborum, like Sabertha said, the abdominal obliques, and the erector spinae. On the high side, there's going to be weakness of the hip abductors. Now we're talking about the low side of the lateral pelvic tilt. There's going to be tightness of the hip abductors because we're trying to keep that leg abducted on the low side. And then on the low side, we're going to have weakness of the hip adductors, the quadratus lumborum, the abdominal obliques, and the erector spinae. Let's share my final thing here. So a lot going on here. But you have to look at it this way. You have to look at the high side, what's happening on the high side, and what's happening on the low side. So joint positions, there's going to be flexion of the spine, obviously, to try to get this to as much as possible level with the other side. Okay, there's going to be the position of the joint here, going to be the hip is going to be in abduction. The position here is going to be, hip is going to be in abduction. Okay, what Sabertha said. On this side, there's going to be, on the low side, the weakness of the hip adductors because this is going to hip abduction. The adductors are going to get weak. The abductors are going to get tight. Okay, the weakness in the hip adductor, like I said, the quadratus lumborum, the abdominal obliques, and the erector spinae, all on this side. Now we're going to the high side. The high side, now all the muscles that I just mentioned are going to get tight because obviously we're trying to shift our weight this way so that we get this leveled. So the tightness is going to be in the adductors because the joint position is in hip adduction. The quadratus lumborum is going to get tight on this side. The obliques are going to get tight on this side. And the erector spinae is going to get tight on this. Okay. The weakness over here is going to be in hip abductors because this hip is going to remain in adduction, which means that this is going to get tight and the abductors are going to get weak. Once again, this one is one that you have to process after you look at my. Why does the high side look lower? It does. It's this, we're looking at this here, and then it's kind of going into this low side here. Maybe it's the picture, but this should definitely be higher. So I would maybe just hike it up a little bit more, but this is definitely higher than this side, as you see in the line going through here, kind of going down. Oh, you're looking at the shoulder. Okay. No. The shoulder, you can look at it because this patient is kind of leaning their trunk over to the high side to try to get this up. Okay, so there's going to be a discrepancy in there, but we're really not focusing on the shoulder for this posture. Did that clarify it, Frank? Okay. All right, we have like half an hour more, and then whatever we don't finish today, we'll cover someday. Let me share. Not Sunday. Hold on one second. I'm just sharing my PowerPoint here. There's so many other muscles that can be tight and weak in these postures. The ones that I want you to remember are the ones that are on the PowerPoints, but there can be so many dysfunctions, so many imbalances with different muscles. As I saw you put rectus there. One. All right. So now we're moving on to scoliosis. And you guys covered scoliosis, right? In medical diseases? Yes, no? Okay. Well, how is scoliosis named? What is it named after? The convexity or the concavity? Okay, perfect. The convexity. Good. Good. All right, we're going to talk about structural scoliosis and non-structural scoliosis. So we really don't go that deep into the actual condition, but we do talk about the two different types. So it's very important for you to know the difference between structural and non-structural, which this picture here kind of sums it up. Structural scoliosis involves irreversible curvature. So this is due to a fracture. This is due to conditions such as osteoporosis or osteomalacia, any type of neuromuscular diseases. It can be pathic, so unknown why it's causing it. So this curve is not going to change. So it doesn't matter what type of position you put the patient in, the curve is not going to change because it's a structural issue. Now we move on to non-structural functional scoliosis, and that means that this can be changed. It can be reduced by sitting or by putting the patient in certain postures. So just to read what it says here, reversible and can be changed with folding or side bending and with positional changes such as lying supine or realignment of the pelvis by correction of a leg length discrepancy or with muscle contractions. So you can strengthen the muscles to provide a little bit more stability, which may help to kind of reduce that curve. That is something that is called functional scoliosis or non-structural scoliosis. Please know both names. You will be tested on this. The common cause for this is leg length discrepancy, muscle guarding, poor postural habits. Okay, so as you see here in the picture, there could be a possible pelvic imbalance which may cause the functional scoliosis that you see here. One leg can be shorter than the other, or one leg bent, may cause the function. Okay, so the sources of pain, muscle fatigue and ligamentous strain on the side of the convexity. Obviously, there's going to be nerve root irritation on the side of the concavity, muscle imbalances, as we're going to talk about below, and potential cardiopulmonary involvement with severe cases if the posterior ribs on the convex side are pushed in a posterior position. It's going to cause that characteristic rib hump that you see there. What would you name this or diagnose this scoliosis that you see here in the picture? Yes, right or left? Left. Okay. Left lumbar, right thoracic. Okay. Okay, good. So with, good. Okay, so with the muscle imbalances that we see here, this picture kind of at the bottom kind of tells you a little bit of what you need to do as far as treatments go. So you see the red is going to be the muscles that are going to become shortened. And again, not necessarily all the muscles are going to be shortened in this area. This is just a generalization. And the blue kind of, as you see here with the spine go into that direction is going to make those muscles longer and weaker eventually. So what we need to do is we need to strengthen, we need to stretch accordingly so that we can get the patient back to as optimal function as possible. So the muscle imbalance are going to be on the concave side, the muscles are going to be tight or shortened. On the convex side, the muscles are going to get overstretched, which in turn will make them weak. This patient in the picture here will be positive for Adams test with rib hump in the thoracic region. So a special test, I think you have a total of 3 special tests for this lecture. I will post 3 videos of 3 special tests that you need to review because you will be tested on them on your final exam, just knowing the name of the test, knowing what it is for, what it is used for. So the Adams test is the one in the next slide. It's used to diagnose scoliosis. I don't know if some of you maybe have done in school. I know when I went to school, they did the scoliosis test on us to make sure that we were okay. But I will post a video. They basically just forward bend, and you would have to see it from the back. As you see here, you see the rib hump in this area, so it has a positive Adams test. All right, so now we get into how are we going to manage all of these faulty postures that we talked about prior. So this is a generalization. This is just kind of covering everything, but obviously we have to tailor our treatments based upon what faulty posture the patient is presenting with. Okay, but before the care is developed by the physical therapist, following assessment is needed to determine the impairments, functional limitations, and participation restrictions that this patient is presenting with. So the PT will check postural alignment, they'll check range of motion, they'll check joint mobility, they'll check flexibility, muscle strength, endurance for repetitions and holding, ergonomic assessment. What does ergonomic assessment mean? Okay, like the office environment, yes. Yes. So that's basically checking how an employee work area, or how can we improve it? How can we make sure that this patient doesn't go back to that faulty stoop posture? Do we have to recommend a higher chair, a chair that elevates a little more? Do we have to recommend a desk that he can move so that he's not sitting all day? Do we have to recommend him to bring the computer closer so that he's not going into that forward head posture to look at the numbers on the computer? So all of these, we just want to make sure what can we do in order to improve and prevent any musculoskeletal disorders from happening to this patient. So that's an ergonomic assessment. We just take a look at the environment that the patient has around their job, or sometimes home if they work from home, their home office. We want to also look at body mechanics, as you see there. So the physical therapist will evaluate the patient picking something up if that's what they do at work, and check their body mechanics to make sure they're doing it properly. Also, cardiopulmonary endurance, aerobic capacity, and breathing patterns, because breathing also has an effect on faulty postures. So all of these are the things that are going to be looked at and evaluated by the physical therapist in order to come up with a plan of care. So treating of postural problems, awareness and control of spinal problems, postural training techniques. So it's very important to use visual cues by using mirrors, verbal cues, tactile cues, to teach a patient how to properly perform these exercises, and all they'll be learning in the lab. Examples of awareness can be axial extension. Axial extension is something that we incorporate when we talk about cervical spine. That's just basically telling the patient to pretend that there's a string on the top of their head and somebody is pulling that string. It's basically to get them to go into that extension and that optimal posture. So that's going to be actually one of the things that you have to do during your competency for cervical spine. For any type of exercise, that's going to be your first step. Pretend you have a string on the top of your head and somebody's pulling you up. So that's what we're going to do to perform all of these exercises. Why? Because we try to promote as upright posture as possible. Scapular retraction is another one. Pelvic tilt, depending on what we're working with, what condition. And then neutral spine is also something that we're going to be working with when we talk about exercise. You want to, for posture, patients with postural problems, you want to reinforce daily checks of posture throughout the day to reinforce proprioception of correct posture. What does this mean? This means that this patient can be on the computer for 2 hours or 8 hours a day. You need to tell that patient, as a patient education, you need to say, so this posture that you're holding for X amount of hours, you need to, every hour, you need to go ahead and just kind of sit up straight, do these couple of exercises, a couple of scapular retractions, just to reset your posture so that we can correct it, so that you can start getting used to this posture versus staying in that rounded shoulder posture. So it's just reinforcing those daily checks or hourly checks or every 2 hours. They can stay at their desk. It's just going ahead and doing maybe some axial extension, some scapular retraction, maybe some posterior or anterior pelvic tilt, depending on what faulty posture they are in. Okay, so that takes me into patient education. You want to explain to the patient the relationship between posture and pain. Some patients don't know until you tell them during the visit, okay, so you're on a computer every day, so you're sitting like this with your shoulders rounded. So that's going to put stress on the muscles in the front, and put stress on the muscles in the back in different ways. It's going to stress your ligaments, your joints. So that is what is causing your pain. And some patients are like, wow, I didn't know that just simply by me sitting upright and trying to take care of my posture more, then I can decrease some of this pain. So patient education is very, very important. Stretching and mobility program for tight structures. So obviously we're going to do manual stretches, joint mobilization, self-stretching, strengthening and stabilization program for the weak muscles, emphasizing the transition of these in functional activities. So we start from a supine position all the way to standing progressions, as you'll see in the lab. The lab is very, very structured because you have certain progressions that you have to know, and there's progressions in different positions. So you'll see how this lab works. It's a little different than the upper and lower extremity because it's so that you have to follow the progressions to a T. Okay, instruct the patient in correct body mechanics is always important. Adapt stress-provoking postures and activities, including stress reduction and relaxation. Okay, and healthy exercise habits, always important to educate our patients. You never want to tell a patient, hey, you need to lose weight. You want to be tactful about that information, about that conversation that you have with the patient. Maybe include the physical therapist. There's a way that you guys can both target the patient in a tactful way, not to say, oh, you need to lose weight, that's why you're having this bad posture. No. So please always be conscious about that, about those type of subjects that are very difficult to talk about sometimes. All right, so considerations. Activity is super important in the management of patients with spinal and postural pain. I've had back pain and it knocks you out. Sometimes you don't do anything, but it is very important for you to do something, whether it be isometrics, whether it be some light stretching, something that doesn't cause pain. But laying down is probably the worst thing that the patient can do. So we always emphasize the importance of activity in management of pain. Patient complaints or neck pain often do not relate to specific pathologies. So a patient may not necessarily have a herniated disc and have some back pain. They may just have overdone it with their working out. They may have the faulty posture due to their work position, but it may not necessarily mean that they have something going on pathologically. Physical therapy treatment should be based on presenting structural and functional elements while respecting the pathomechanics, the pathophysiology, and the precautions of a specific diagnosis. So this basically just means that you have to follow any type of precaution, any type of rule, so to speak, that is imposed by having a specific pathology. So you're going to know about those in the next couple of slides, because there are certain conditions that not do any flexion exercises at the beginning, or there are certain conditions that we cannot do any extension exercises in the beginning, or else we would increase the pain or worsen symptoms. So this lab is very specific because it covers certain conditions. With certain conditions, you can do flexion exercises. With certain conditions, you can do extension exercises. If you are in your comp and you're doing extension exercises for a flexion-based patient, you're hurting that patient, essentially, because you're doing the opposite of what should be done during the first couple stages of the treatment. And you'll see what I mean in the next couple of slides. I think we're going to be able to get through disc herniation, and then we'll kind of stop so you guys can come to campus. So pathology of the intervertebral disc. What is the most common herniated nucleus pulposus? What is the most common herniation? Posterior lateral, yep. So posterior lateral. All right, so talking about the pathology of the intervertebral disc, I think you've seen this slide before in another class. So when we're talking about, if you recall that jelly donut that I talked about, this is how you're going to think about disc herniation. So disc herniation is just that general term where there is a change in the shape of the annulus that causes it to bulge beyond its normal shape. We're going to talk about starting with generation, which is also called disc protrusion. So it's that nucleus you see here bulging against an intact annulus fibrosus. So that's you squeezing, let's say it's the same jelly donut, but there's no hole in the donut. They closed it, they sealed it all around. So you're putting pressure on that donut, and the jelly in the middle is hitting against the intact annulus fibrosus, meaning that there is no tear whatsoever, but it's still pushing against it. Okay, then we talk about disc prolapse, which is when that jelly or that nucleus migrates towards the outer fibers of the annulus. So now it's going a little bit further towards the edge of that donut or that annulus, whatever you want to think about, but it's still being held within that donut. It hasn't made a hole in it yet. Okay, then we have disc extrusion, which that jelly kind of goes through. Now it's broken through the annulus or through the dough on the donut. So now it's moving into that epidural space. However, it's going to be confined by that posterior longitudinal ligament that we talked about. That kind of protects it a little bit. It doesn't protect all of it, which is why we have posterior lateral disc herniations. Then we have disc sequestration, in which the nucleus kind of goes into the spinal canal. So possible fragments of the annulus free within that spinal canal. Do you think that this is an immediate cause for surgery, the disc sequestration? So no, it's not. A lot of the sequestration is treated conservatively with back surgery. Just know that back surgery is something that somebody does as a last resort. Back surgery is serious. You can get really hurt from back surgery because obviously you can get hurt or die from any surgery. They have you sign that when you do surgery, when you have surgery. But back surgery is particularly, there's a lot of nerves around. Many things can go wrong with back surgery. So sequestration is not necessarily always treated. It's mostly treated conservatively. So what happens is that the body kind of reabsorbs the possible fragments that go into the spinal canal. They don't know how or why, but it is, I want you to know that it's not an immediate, we're going to see right away when there's a disc sequestration. Now, a sequestered disc may impinge a nerve depending on where it ends up in the spinal canal. So that's another thing, that it increases the possibility of nerve root impingement, because whatever just fell out of that aneurysm going into the spinal canal, it can end up in different areas that can obviously impinge nerves or cause a lot of symptoms, of nervous system symptoms. Okay, so did everybody understand the degeneration all the way down to sequestration? Yes, no? Okay. Can a patient with a prolapse ever be able to decrease the prolapse back to the middle with, your question went away, with proper treatment? Yes. So yes, it will go back sometimes. But like I said, if it's already in that stage of prolapse, the patient may just do a movement that is out of the ordinary or twist in the wrong direction, and it can just go right back to that same, and restart the process once again. Because it goes back to, that's very avascular and it's very aneural, so it's very poor, it's a very poor healer. So when you have a herniated disc, you pretty much have it for the rest of your life. You just manage it. Did that answer your question, Elizabeth? So it can never really go away. We just treat the pain. We treat the symptoms and the pain. We do modifications for that patient to make sure that they stay away from the positions that will bring it back. But typically, it will always be there. And I read an article a couple of years ago where it says everybody, if you get an MRI, if all of us get an MRI, we each have some type of disc herniation that we just don't know about, which was very interesting. I'll see if I can find it and post it, whoever wants to read it. All right, so pathology of the interval disc. The disc can be damaged through different types of mechanics. So it can be repeated overloading of the spine and flexion and reflection with any type of rotational forces or stresses, torsional stresses and or flexion stresses. The annulus fibers are going to stretch and tear. To answer Elizabeth's question before, it attempts to heal, but it's very hypovascular. So it really has very, very poor healing capabilities. It can be due to a traumatic rupture, due to a car accident, occurs with a traumatic hyperflexion injury, which can involve some type of rotation as well. It can be due to any type of degenerative changes going on, so due to a condition or infection, and herniation. Progressive fibrous changes in the nucleus may also lead to a herniated disc. As the nucleus becomes more fibrotic, it loses the ability to absorb water, which is going to decrease the size of the disc. The change in the size of the disc changes obvious spinal mechanics, because not all the discs are going to be the same, because one has lost the ability to absorb water, so it's going to be different. So it's going to throw everything off. It can place, the example that you see here is it can place forces on other structures, such as the facets, the ligaments. So now they have to work extra hard to try to keep that spine nice and stable because of the lack of size in the disc that is affected. So very important to know the effects of flexion and extension on the pathological disc. So with extension, there is an anterior migration of the nucleus pulposus, and there's also a narrowing of the intervertebral foramen. Now with flexion, there's a posterior migration of the nucleus pulposus, and there's a widening of the intervertebral foramen. So just by looking at this, what do you think, what type of exercises do you think that a patient with a posterior lateral disc herniation may benefit from? Flexion or extension exercises. So it would be extension exercises that would be for this patient. Yes. And the reason why is because we're trying to get that posterior lateral disc herniation that is in this area to go in back to where it belongs, right? So if we do flexion, what we're doing is we're bending this forward and we're actually encouraging the posterior lateral disc herniation that's here to go out more. So flexion is always contraindicated for a patient that has a posterior lateral disc herniation. This is not going to be the case for the entire patient's life. This is just going to be for the time that we're treating the patient. It's not like we're going to tell this patient, you can never, ever, ever do flexion again. It's just that we're trying to focus on what is going to be painless, and also so that we can strengthen patients and stabilize patient's spine. So it's not like a contraindication that's for life. It's just a contraindication for the span of the treatment seeing this patient for when they have symptoms. Okay, so I want you to know the exercises are called Mackenzie's extension exercises. Mackenzie's extension, and we have for flexions exercises, they're called Williams flexion exercises. And these are the plans that we're going to be covering in lab. So for those patients that require flexion exercises, it's going to be Williams exercises. For those patients that require extension exercise, it's going to be Mackenzie's. So please write that down. I believe it's in some of the slides already, but just make sure that you know that a Mackenzie program would be an extension program and a Williams program would be a flexion program. Did everybody understand the reasoning behind why we wouldn't go into flexion? Okay. So what is the, I'm going to cover like 6 more slides. All right, so postures and their effect on the disc. So for a pathological disc, we talked about it already. In a flex posture, the nucleus pulposus is going to move posteriorly, which is why we don't want to do flexion exercises for a posterior lateral disc herniation. In an extended posture, the nucleus pulposus is going to move anteriorly, and that's what we want. We want to push it back into the center. So that's why we go with extension exercises. Not all herniations are going to be symptomatic. If they are symptomatic, pressure from the disc on the nerve roots and ligaments and or the dura mater may happen. So patients may have a disc herniation and not feel any symptoms whatsoever. So that's just something that we have to know. Signs and symptoms for posterior lateral disc pathology. There's going to be certain midline back pain, which can spread into the buttock and to the thigh or further down the lower extremity, depending on what is being impinged. A large posterior lateral problem may cause also spinal nerve root symptoms, such as sensation loss, muscle weakness. A large posterior lateral problem may cause partial spinal cord symptoms, so issues with controlling of the bladder or saddle anesthesia. Saddle anesthesia, if you want to write down, is a loss of sensation to the area of the buttocks, the perineum, and the inner thighs. Loss of sensation. Let me just type it. So that's what saddle anesthesia refers to. Inflammation in the area can create or increase that pain with flexion activities. So these patients are probably going to have the most pain when they sit down because they're in flexion. And flexion increases those symptoms, which is why we go for extension. Coughing or attempting to stand after sitting and to be very painful for them because they've stayed in that sitting position for a while. Usually with a posterior lateral HNP or herniated nucleus pulposus, the patient will be most comfortable lying in a supine position. Because if they go into seated, they're to that flex position, which causes more and more those symptoms to come to the surface. Pain generally decreases with walking and standing, obviously, because they're in that extended posture. So they're going to prefer to walk, to stand rather than having a seat, because if they go into that flex position, that's just going to increase symptoms. Okay, 50% of the patients are going to have a lateral thoracic shift, so away from the protrusion. So they're going to go ahead and just kind of shift to the side away from it. During this, if you treat the patient in the early stages, our main goal is going to be to kind of correct this shift. We will have them in midline so that we can then work on strengthening and stabilization. But if you don't have them in midline, it's most important to maybe treat them with modalities, with soft tissue, to try to kind of correct that lateral shift. Then we can work on strengthening and stabilizing in the position of extension. Range of motion flexion is going to be decreased, obviously, because it's going to hurt them more. Repeated flex tests are going to cause pain to peripheralize because they're going to compress more on that posterior lateral disc herniation, and the pain is just going to travel down the leg. Extension is going to be decreased also. However, the pain should be centralized. If not, due to the lateral shift. So what is important to correct first before we work on any type of strengthening or stabilization? From what I said. So let's say I have a right L4, L5 posterior lateral disc herniation. Where am I going to be shifting to? What side am I going to be shifting to? I have a right posterior lateral disc herniation. For what I said, your patient is always going to shift away from the protrusion. So I'm going to be shifting to the left, right, to try to get away from that compression that's happening. So that's how your patient's probably going to present. So what you want to do is first you want to calm the pain, calm everything that's going on with modalities, and then you want to correct that shift to try to get them back to midline. And then after that, we would focus on our extension exercises. Okay, so we're going to stop here. Slide 59. Okay, guys, so we're going to continue this presentation. I believe I covered some of this slide, but let's just go ahead and kind of review it a little bit more. 50% of the patients that have a posterior lateral disc herniation are going to present with a lateral thoracic shift. What that means is that the patient, if they have a right posterior lateral disc herniation, their trunk is going, the thoracic spine is going to lean away from that shift. And it's basically just a protective mechanism that the patient does in order to get away from that pain. Obviously, the greater the herniation, the more difficulty we are going to find with trying to correct that shift. So we may have to treat them with modalities to try to bring down some of that pain and some of that discomfort. Once that is treated with modalities or soft tissue mobilization, if the patient is able to withstand or allow you to put your hands on them, then we go ahead and try to correct that shift. Range of motion and flexion is going to be decreased. Repeated flexion examinations are going to cause pain, so we usually don't do any test in flexion for like range of motion or any type of other measurement that we have to put the patient in flexion of the spine. That is just going to increase that pain. It's going to peripheralize. It's going to go down to the extremities. As you see here, it can just go down. What we're trying to do here is trying to prevent this from staying like this with the peripheralization. We're trying to have that pain kind of centralized. So it's kind of slowly just coming to one area. So this on the right here, where you see my mouse, is what we're trying to do. We're not trying to obviously cause anything that is going to increase that pain or peripheralize that pain. Extension is going to be decreased as well. So it doesn't necessarily mean that just because flexion is decreased, extension is going to be increased. So extension also will be decreased. However, that pain with any extension activity should centralize. So it should be this little dot right here in the lumbar spine. It should stay within that area, which is what we want. Due to the lateral shift, extension is going to decrease also. However, the pain should centralize. If not, it may be due to that lateral shift. So like I said in that earlier in the slide, we want to correct that shift, and then we want to try extension exercises. If repeated extension peripheralizes pain, then it cannot be mechanically reduced. So there's also going to be muscle guarding. There's also going to be inflammation in these patients. Okay, so how do we treat? How do we treat the posterior lateral disc herniation? It can be with or without nerve root involvement. So it just depends on the severity of the herniation if it's going to involve a nerve root impingement. So in the acute stage, modalities such as ice, electrical stimulation, all of those modalities that we are free and clear to use during those acute stages. You want to correct the lateral thoracic shift and educate the patient in correcting this. So we don't want to promote that patient going into that lateral shift. We want them to be in midline. So we want to maybe position them appropriately, maybe with a couple of pillows, and eventually gravity will kind of pull them into midline. So we just want to educate them that it's important for them to be at midline so that we can finally start working on stabilizing and strengthening the core in midline, not with that thoracic shift. McKenzie's mechanical decompression, you want to start the patient in prone lying, so lying in a prone position. The patient may need to start with a couple of pillows just to kind of help put that spine in neutral, and gradually work themselves into that extension. They might not be able to just completely go flat prone on the bed. So you might need to slowly remove pillows, a couple of pillows a few minutes later until they finally get into that full extension. The time that we're spending with patients in the prone position may vary depending on the severity of the patient's condition. This you progress by going to prone on elbows, and then prone on hands, and then standing extension. As you will see in the lab, these are going to be your McKenzie's stretches. So basically we start in a prone position, then we go prone on elbows, then prone on hands, and then finally our final stretch in the McKenzie progression of stretches is going to be standing extension. If the pathology is severe in this particular patient, the patient may need a walker to ambulate. That's how bad it gets for some patients. They may also need a lumbar brace dependent upon who the doctor is that's treating the patient. Sometimes if we just put a brace on just for a little bit more stability, because the patient's physiological brace that we talked about prior slides is not working properly due to this posterior lateral disc herniation. So everything is kind of going crazy due to the herniation that the patient is having. So the brace may add a little bit of support to the patient. But again, it's not something that should be worn for an extended period of time, because obviously the brace is doing the work that the muscles should be doing. Patient education, very, very important, as you already know. Lumbar roll for spine neutral and sitting position. Sit for shorter periods of time, because if the longer you sit, the more it's going to hurt when you get up from that position, because you've been sedentary for so long. You want to teach them proper body mechanics for sit to stand to avoid forward bending, because that will increase the pain. Walk and stand as tolerated, teaching sleeping postures. So use a pillow for support, for side lying and for prone sleeping. As you know, prone laying kind of increases that lordosis. So what we want to do is have that neutral spine with this patient. So we want to make sure that we educate them. Hey, if you sleep on your stomach, go ahead and put a pillow underneath your belly so that we can keep that spine nice and neutral and prevent any increased pain. Teach them how to log roll, so it's not getting out of bed, just propelling yourself up in that supine position and then going to long sitting. It's turning to the side, log rolling, and just breaking it into segments just to prevent any type of exacerbation of any symptom. We want to avoid forward bending activities. Use the legs rather than the back. So you want to go ahead and lift with your legs, not your back. All the things we learned regarding body mechanics, we want to pass along to our patients to protect their back, especially during this acute stage. Okay, so contraindications, very, very important to remember. The contraindications for an acute herniated nucleus pulposus, isometrics are going to increase the abdominal pressure. What do we know about abdominal pressure? It increases the strain, so to speak, on that spine because it provides stability, but it also increases that pressure, which will push against the spine and maybe increase the patient's pain. We want to avoid the Valsalva maneuver. We avoid the Valsalva maneuver with everything we do as far as exercise goes, as far as functional mobility. We never want the patient to hold their breath. And we want to avoid any movements that peripheralize pain. So anything that is going to just bring that pain from that central area that we want to see down to the lower extremity, anything like that, we need to discontinue and maybe try it when the patient's symptoms have subsided. It doesn't necessarily mean that you are never going to do those things, but it just means that during this acute stage, we want to avoid anything that is going to get that pain to spread down the lower extremity. And as you see here in the picture, it's just a couple of techniques to kind of log roll out of bed. They can do the bridging, they can do supine to side lying, bracing with their arms across their chest before they're doing it, bracing by putting a pillow in between their legs. So these are just different techniques that you can teach your patient to adapt at home. Okay, so treatment for posterior lateral with or without nerve involvement. Now we're moving on to the subacute and the chronic stages. Subacute and chronic, we want to go ahead and continue with our McKenzie's strengthening exercises. So now we've stretched. Now we're going into McKenzie strengthening. We're going into lumbar stabilization exercises. You want to treat any other type of postural imbalances that the patient is having. If your patient shows up and they're deconditioned due to having pain for 2 to 3 months, aerobic exercise may be recommended for that patient. And then patient education. Obviously, patient education is going to include postural awareness exercises. Make sure you do your daily postural checks if you're going back to work. Make sure that you're lifting with your legs and not with your back. Just watch your movements. Watch your movements throughout your daily life and make sure that you make the proper adjustments and don't go back to doing the movement that you did when you got hurt. Or if it was due to a traumatic injury, that may be different, but still there may need to be modifications made to the patient's daily life or just adjustments made to kind of prevent any movements that are going to bring on a period of exacerbation. Okay, so you see some exercises here that are part of the McKenzie's extension exercises, which we're going to cover in detail in lab. Okay, then we move on to sciatica. Sciatica is caused by a compression, or it can be irritation of one of the 5 nerve roots from L4 to S3 that make up your sciatic nerve. This is also referred to as lumbar radiculopathy or radiculitis if it's accompanied by inflammation. So if it's just pain that's going down the leg, it's called radiculopathy, but if there is inflammation present, then it can be referred to as radiculitis. Or it can also be a compression of the sciatic nerve itself. So there's different causes for this that can cause this. You've probably heard of piriformis syndrome. That is usually one of the, when the piriformis is tight. The piriformis sits right on top of the sciatic nerve, which obviously when the muscle gets tight, it's going to compress in that area and it's going to send nerve-like symptoms down the extremity. Pain is usually going to be felt in the lower back and or buttock area or the lower extremity. There may be numbness, there may be tingling, obviously there may be some muscle weakness due to this irritation of this nerve not being able to supply the muscles that it supplies appropriately because it is irritated or being compressed. Causes of sciatica, like I said, there's many. The main one would be our piriformis syndrome, but it can also be caused by disc herniation when there's nerve root involvement, degenerative joint disease, spondylosis, osteoarthritis because of all that degeneration, any misalignment of the vertebrae, specifically spondylolisthesis, any type of stenosis, a narrowing that will compress the sciatic nerve, trigger points or spasms in the area surrounding that nerve, piriformis syndrome I already mentioned, pregnancy, SI joint dysfunction can also be a cause for sciatica. Okay, so we have a special test for sciatica. Performing the test, this is the long description of the test. This on the right here, it's called a slump test. It is basically the test to see if the patient is positive for sciatica. So if you want to try this on your own, you slump your shoulders down towards your hip, you bring your chin towards your chest, you slowly straighten one knee and you pull your toes towards your shins or towards your nose, toes towards your nose. A positive test will reproduce pain and suggests a neural tension. That means that your sciatic nerve is not gliding normally. There is tension in the sciatic nerve, which could be indicative of a positive for sciatica or sciatic nerve involvement. This is also the same position that we use for nerve glides, which I think you'll learn a little bit about in therapeutic exercise 2. Okay, treatment for sciatica. Treatment for sciatica is really based upon what impairments the patient presents with. So depends, it can include stretching exercises. So we stretch the piriformis if the piriformis is tight, stretch the hamstrings as well. Stabilize and strengthening exercises, also appropriate depending on what is weak, what is lengthened, what is tight. Neuromobilization techniques, which I just showed you, the nerve glide for the sciatic. Treat any other postural imbalances. Obviously, we want to make sure that the patient has optimal posture or as optimal posture as possible. Aerobic exercise if the patient is deconditioned due to being in pain for so long, and modalities as needed. So maybe a soft tissue massage to kind of release the tightness in the piriformis muscle. It could be an ice pack if the patient is in the acute stage and maybe some inflammation is present. If you have radiculitis, which is where there's inflammation. So there's a ton of things that you can do, but it's mostly dependent upon the impairments that the patient presents with. So then we move on to lumbar sprain or strain. Generally, it's going to occur due to a fall, excessive lifting or twisting, or any type of overuse activity. Common clinical signs are going to be pain along the iliac crest, muscle guarding or tenderness in the area. Inflammation may be present, pain with flexion due to stretching involved muscles, or extension because of contracting them. Radicular pain is really rare, so pain doesn't radiate down with a lumbar sprain or strain, but it may be present in some patients, but it's very rare. So with this, if you see pain with flexion due to stretching involved muscles or extension because of contracting them, in order to decide what type of exercises we are going to do, we have to see what the patient has pain or what increases that pain. So if the patient has pain with flexion, we're obviously not going to go with a Williams flexion based exercise program. We're going to stick with our McKenzie's. But if my patient has pain with extension, I am going to not do the extension exercises. I'm going to go with Williams. So this is one of the conditions that you can do either or. It depends what is increasing the symptoms in your patient. If your patient says, I have pain tying my shoes, so pain tying their shoes means that they're having pain with flexion of the spine. So that will tell me, okay, so you have pain when you bend your spine forward. So we're gonna go ahead and just get started with some exercises to try to get working on those on extension, strengthening, and stabilization techniques. Once you have no pain, once you're a little stronger, then maybe we'll try Williams flexion just to see how you're feeling and if what we have done in the McKenzie's program has actually helped. And now we can progress you to Williams exercises as well. So the treatment, I just kind of gave away the second slide, number 2 right there on the under treatment, because we want to start with the Therex progression that is not painful. So it can be either or. If you get a lumbar sprain or strain in your comp, you have to make sure that you ask your patient, what is it that you're having pain with? Is it when you stand for long periods of time? Is it when you reach down to tie your shoes or reach down to put on your socks? And then you, from there, from that information, you have to decide what plan you have to use with that patient. Modalities, definitely use modalities. You want to know the differentiation between using them in acute versus chronic. I'm pretty sure you're good with that. You know what not to use in the acute stages, and you know what we should use in the chronic stages. You want to obviously stretch anything that is tight and strengthen anything that is long and weak. You want to progress to lumbar stabilization exercises. Patient education should include everything that we mentioned before on patient education, so body mechanics, positioning while they're sleeping, positioning while they're performing their ADLs, using a lumbar roll when seated just to kind of support the spine a little bit more. Okay, so then we move on to spondylosis, degenerative joint disease, and osteoarthritis. So these are all degenerative diseases, degenerative processes. Spondylosis is just basically a degenerative process affecting the vertebral discs and the facet joints that gradually develops with the patient's aging. So these are chronic, they're progressive degenerations of the facet joints. As you see here in the illustration to the right, there's a lot of degeneration going on here. There is hypertrophic arthritis on the facet joints. There's narrowing of that intervertebral foramen, which will compress the nerve roots. There is reduced height of the intervertebral discs themselves. There's bone spurs or hypertrophic bone formation right there that you see right here. And so all of this is going to have an effect on patient function. It's going to increase patient symptoms. So I just went through everything that is in the slide, that is in the illustration there. So possible bone spurs, dehydration of the disc that flattens it out, as you see there. There's going to be approximation of those facet joints. There's going to be narrowing of the intervertebral foramen. So those spinal roots are going to get compressed, and that's going to send radicular symptoms and numbness, tingling down the extremities. Past medical history, the patient can have a history of back problems, which can lead to these conditions. And they generally are going to have postural issues. All right, so continuing on for the treatment of spondylosis, degenerative joint disease, and osteoarthritis. Clinical signs, and then we're going to talk a little bit about symptoms. So clinical signs, there can be pain over the involved segments and into the muscles that are surrounding that segment. If the intervertebral disc is involved, flexion is going to cause more pain. So that's only if the intervertebral disc is involved. If the facet joints are involved, extension is going to cause more pain. So as you know from the beginning of the presentation, of this PowerPoint presentation, you guys saw that when we go into flexion of the spine, the pressure or the area that is coming together is going to be the anterior portion of the spine. So if that disc is involved, flexion is going to cause more pain in these patients, meaning that we're going to start with an extension-based plan when we talk about exercise. So if the facet joints are involved, that means that if that patient goes into extension, those facet joints are going to come closer together, meaning they're going to impinge even more and cause more pain. So we want to stick with a flexion-based plan or a Williams-based plan for that patient. So that kind of gears our treatment. Treatment, as you see, all of them have in common modalities. Modalities play a big role in those early stages and maybe towards the subacute and chronic stages as well, dependent upon the patient and the clinic. You want to improve flexibility of the tight muscles. You want to strengthen always the weak muscles. You want to exercise opposite the direction of pain. So that's what I talked about. If the intervertebral disc is involved, you want to go ahead and do McKenzie's extension because flexion is going to cause more pain. If the facet joints are involved, you want to do Williams flexion because extension will cause more pain. You want to progress the stabilization exercises. And you want to teach, obviously, patient education is a very, very important portion of this. You should teach them on proper posture, proper sleeping positioning, proper positioning for their ADLs. So all of this should be included in your patient education. Moving on to spondylolysis versus spondylolisthesis. So spondylolysis is a fracture only on one side at the pars interarticularis. This is between the superior and inferior facets. So it's this area here. There is a fracture on one side. This is just showing you where the pars interarticularis is. This right here is spondylolysis because there is a fracture just on one side of that pars. And then when we have spondylolisthesis, both sides of the pars interarticularis have fractured. And now this vertebrae is slipping anteriorly, as you see here in this illustration. Both are most common at L4, L5, and L5S1. Very, very important for you to remember where the most common spondylolisthesis and spondylolysis happen at the level of the spine. Okay, so spondylolysis and spondylolisthesis treatments are pretty much the same for both. Causes can be mechanical, vertebral weakness, excessive extension. It often happens in gymnasts. It can be congenital, weakness or fatigue or fracture. Clinical signs, there's going to be pain with extension. So if there's pain with extension, you already know what plan you have to use with this patient, what type of strengthening exercises you have to use with this patient. You would use a Williams flexion exercises because extension is just going to push that disc forward. There may be a palpable step off with spondylolisthesis, so you might be able to feel. Palpable step off. Standing is going to increase pain. Standing increases pain because it brings gravity acting upon it. So with, you see here that it causes pain with extension. So standing is going to increase that pain. Sitting because it's going into flexion and that pars interarticularis or the slipped vertebrae kind of goes back into place because we're going into that flexion. So sitting will reduce pain in these patients. So the treatment, if in the acute stage, you want to treat modalities, no traction, please make sure that you know that it is a contraindication to use traction on a patient with spondylolysis or spondylolisthesis. Contraindication is also extension-based exercises because that is just going to push that slipped vertebrae forward even more. So we want to avoid any type of extension-based exercises. We want to avoid any overhead lifting or vertical loading, meaning that we don't want to add more weight to gravity because that's just going to cause more pain because extension is going to cause more pain. So standing and then adding more weight, that's just going to increase the pressure on the spine, on the vertebrae, and it's going to push it forward even more. If in the acute stage modalities, like I said, no traction, they may need or have a lumbar brace. They can begin Williams flexion exercises. After it's healed, we want to work towards neutral spine stabilization exercises. You want to stretch the tight structures. You want to strengthen the weak structures, not during the acute stage, but as they progress. And patient education, just want to educate them on proper body mechanics and proper positioning when they're doing their activities of daily living or just activities in general. Then we move on to spinal stenosis. There are two types of spinal stenosis. So we have central stenosis, which is the narrowing of that vertebral foramen where the spinal cord runs through. So obviously narrowing or that foramen getting smaller is going to lead to spinal cord compression. Okay, so it can be due to bone growth that pushes on the spinal cord. And then we have lateral stenosis, which you see here on the right, which is the narrowing of the intervertebral foramen that leads the spinal nerve roots. It leads to spinal compression when that becomes smaller or stenosis starts to happen. So it can be caused by a disc herniation, it can be caused by inflammation, it can be congenital, it can be caused by spondylosis, by osteophyte formation or bone growth, bone spur formation. Abnormal bone growth can also narrow these two areas, or abnormal tissue hyperplasia. So if there is tissue growth that is compressing in these areas, it's going to cause these areas to get smaller, meaning that the spinal cord is going to start to get compressed, and then the nerves are going to start to get compressed if it's happening in the lateral portion of it. So clinical signs, and then we're talking a little bit about treatment. Clinical signs, there's going to be pain in the low back, and in one, if lateral, one, or both if central. So if it's lateral stenosis, there may be just pain on one side or on one extremity. And if it is spinal stenosis, or if it's central, both of the legs are going to be affected by paresthesias, by numbness, tingling. There can be paresthesia in the extremity. There can be disturbance of motor function, so a decrease in the deep tendon reflexes. There can be increased pain with extension. Patient will present with forward trunk flexion with ambulation, because that is going to be the place where they're going to be presenting with least amount of pain. So since you see that the patient is going to go into forward trunk flexion, it kind of tells you what exercises you should be doing with that patient to try to get that patient as strong as possible, and then working towards that neutral spine when they go into the later stages of their condition. So modalities, traction is indicated only for lateral stenosis. Please make sure that you know that it is not indicated for central stenosis. Okay, flexion exercises are the ones that are used. So we use a Williams strengthening and stabilization. We want to progress the stabilization exercises. We want to provide the patient with patient education regarding body mechanics, positioning, contraindications. I already said them. So extension therex is going to increase that pain, because with extension, we're compressing those facets, and we're compressing the space within the central, within the spinal cord, where the spinal cord runs through. So with flexion, we're increasing that pressure that's in there. So that's why we want to go ahead and make sure that we do our flexion exercises. Okay, with extension, we would increase that space, those spaces that we're talking about. Contraindication, traction for central stenosis is extremely important for you to remember. Only traction for lateral stenosis. Okay, so facet joint pathology. The facet joints, as you know, are the synovial joints. A facet joint sprain or a capsule injury can be generally due to trauma. Clinical signs are going to be obviously a limitation in range of motion. There can be inflammation, there can be muscle guarding depending on how serious the pathology is. Osteoarthritis and rheumatoid arthritis can lead to lateral stenosis. Facet joint impingement, also known as entrapment. Those clinical signs are going to be pain, muscle guarding, usually occurs with flexion and rotation together. Generally pain-free if the patient is not moving, but once that patient gets to moving or doing some activity, there's going to be some pain because of that impingement. No true neurological signs. Mobilization and traction are going to be helpful for this patient. And flexion decreases pain. Extension is going to increase the pain. Obviously, with extension exercises, the facets are coming closer together, which will increase that impingement. It'll increase that entrapment. So we stick with our flexion exercises so that we can increase the space in that area rather than decrease it. Okay, and then we're talking our last condition that we're going to talk about, or it for the lumbar spine, is going to be compression fractures. So compression fractures, you always want to link it to osteoporosis. So this occurs mostly in the thoracolumbar region as a result of axial elongation or trunk flexion. So you know the osteoporosis is obviously going to be that decreased bone density. So these patients are going to go into this stoop posture that you see here. They usually end up in this kyphotic posture with all that pressure. They're going to go ahead and have these compression fractures because the spine is getting compressed. Symptoms are going to be provoked by any type of flexion activity. We're trying to get away from that stoop posture. So just think of it this way. You're trying to promote optimal posture. So we go towards extension-based exercises because anything in flexion is just going to increase that compression on that spine, on the vertebral bodies, and it's going to increase or maybe exacerbate some of the symptoms that the patient is having. So for this one, we would want to work with Mackenzie's extension exercises. Okay, so we're moving on to the cervical spine. The cervical spine is very short. It's just a few conditions and then a couple of surgical procedures that are used both for the cervical spine and for the lumbar spine. So the cervical spine, we're going to start with whiplash, or also known as cervical acceleration injury. This happens usually due to a motor vehicle accident, and it's that acceleration of the head and the neck relative to the body. Usually the mechanism of injury is somebody that is in a car and struck from behind, or a sports collision. It's also known as hyperextension injury. So the body moves forward, but the head kind of whips back into place, as you see here, into hyperextension. So there's going to be a sprain or strain of cervical tissues. The posterior structures are going to get compressed with this mechanism that you see here on the picture on the left. The facet joints, the capsule, all of those are going to get compressed. The sternocleidomastoid, the infra and suprahyoid muscles, the longus capitis, longus colli also may be torn or stretched depending on how aggressive the force is. There's generally little pain right after, and motion is fairly good. However, 24 to 48 hours later, pain and stiffness slowly starts to develop. So they might be fine. You might be fine at the site of the accident. You say, no, I'm fine. I don't need to get checked out. But then 24 hours later, it's going to start to develop, and you're going to start feeling those symptoms. During the acute stage of whiplash, we want to decrease those muscle spasms. They're generally very severe. The sternocleidomastoid may pull the head into flexion. There may be a lot of tenderness over those injured muscles. There's very little active range of motion, limited passive range of motion. So what do we do with with this clinical picture that the patient presents with? So our treatment can be to relax those muscles, maybe wearing a soft collar to protect it in place. Modalities may be indicated. passive range of motion just to keep the little bit of range that is available, icing at home just to decrease some of that inflammation, maybe decrease some of the swelling, and patient education on proper posture. So they make sure not to re-injure or exacerbate or increase that pain that they're having. During the subacute stages of whiplash, continue with soft tissue work. Isometrics may be introduced during the subacute stage. They may begin to work on postural muscles if it is not painful, only if it is not painful. You want to progress from passive range of motion to now active range of motion of the cervical spine. You want to be careful with stretching. It really depends on the patient. If you're initiating a stretch and just with a little bit of movement the patient is having pain, you should discontinue those stretches, and you may need to wait until the chronic stage. For chronic treatments, we want to continue. We want to start, if we haven't already started, gentle stretching. We want to gradually restore the normal cervical lordosis curve, the lordotic curve. You want to strengthen any postural muscles. You want to be careful with when you're performing chin tucks because it will help to stretch the suboccipital muscles, but it can flatten that curve that we worked so hard to restore. So we don't want to really do that many chin tucks longer than 6 weeks because we don't want to affect the normal postural curve of the cervical spine. You want to progress with scapular strengthening and stabilization. This comes from your upper extremity exercises that you learned. You want to stabilize those scapular muscles to kind of provide that optimal posture. And you want to progress to cervical stabilization exercises. Okay, then we briefly talk about herniated nucleus with or without nerve root involvement of the cervical spine. It can happen. Generally, if it happens posterior lateral as well at C6, C7, or C5, C6. The patient may hold their head in lateral flexion or rotation away from the symptomatic side. Just as we had that thoracic shift, we also have the lateral flexion and rotation away from the symptomatic side because it's just a protective mechanism to try to stay away from that painful area, to try to reduce some of that pressure in that painful area. The patient may present with a forward head posture. There may be pain with flexion, possibly with mid-scapular or radiating arm pain. Axial extension followed by correction of posture is going to centralize that pain. So that's what we want to do. We want to work on axial extension, and we also want to work on posture correction to kind of reduce some of that radiating pain and bring it into a central area. So for treatment for cervical disc herniation, the patient may have a soft collar. You can use modalities. Recall traction from modalities class, very short periods of time from 5 to 10 minutes because it is a disc herniation. Static traction would be best if you recall from modalities. You want to return them to normal posture through either stretching any muscles that are tight, strengthening any muscles that are weak. You want to provide them with education on postural checks throughout the day. Make sure that they're using proper posture when they're doing their activities of daily living or their recreational activities. What is contraindicated is going to be isometrics because it increases the disc pressure. The Valsalva maneuver, always contraindicated. And obviously any movements or any exercises that you're doing with them that increase the peripheralization of the pain, make that pain go down the leg or down the arm, anything like that is always going to be contraindicated. Then we move on to torticollis. Torticollis is involvement of the sternocleidomastoid. So lateral flexion to the same side and rotation to the opposite side. As you see here, it can be congenital. So the baby can be born with this. It may occur at utero or during birth. It can be due to asymmetrical weakness in patients with hemiplegia due to a CVA, or it can be hysterical, or also referred to as psychogenic, meaning that when a patient turns away from an unpleasant situation, they may strain the SCM and they may get torticollis for a period of time, maybe a few days or so. Or when you sleep wrong, sometimes you wake up with torticollis. This would be due to a positional strain of the sternocleidomastoid. It can be other muscles in the area as well. Treatment for this is just gentle stretching and positioning to try to get the patient back to normal. Okay, we have one special test for the cervical spine. In this test, it's called the Sperling's test. The examiner turns the patient's head to the affected side while extending and applying a downward pressure to the top of the patient's head. So this patient here is, the pressure is being placed by the therapist's left hand down. So a positive Sperling sign is going to be when that pain is coming from the neck and it's radiating in the direction of the corresponding dermatome on the same side. Okay, so this indicates there's foraminal compression because the patient is having that neck pain that's radiating down the arm. And there's a video for this. Please make sure that you watch it. It's much easier to understand when you're watching the video and the person describing the test while they're performing it. And these here are just a couple of pages in the book that I need you to review. It would be very important just to review these boxes for testing purposes. Okay, and then our final couple of slides are talking about spinal surgeries. So as you know, spinal surgery is no easy decision. The patient has to be, have tried other areas before they're reaching their decision of finally having spinal surgery. Spinal surgeries can be minimally invasive, so they can be done through an arthroscope. There can also be done open. So the physician really is the one that determines what technique they're going to use, whether it be an arthroscope or an open procedure based off of the patient's pathology and the extent of the problem. Spinal fusion is fusing of the spine by using those hooks, plates, rods, screws, or cages. As you see here, this will be a cage. In order to fuse the spine to stabilize it. So this is a patient that has an unstable spine, has suffered from this for years, and they're going to use all of these instrumentation that I talked about, the hooks, the plates, the rods, to kind of stabilize it and provide that patient more stability. In conjunction with spinal instrumentation, bone grafts can also be used around the implants. Why? To facilitate that bone growth and to facilitate the spinal fusion and make it as stable as possible. The patients are also sometimes provided with bone growth stimulators that are used in patients who are high risk for failed fusions. So a patient that is a diabetic, a patient that is a smoker, that may have their healing may be delayed. Sometimes they use these bone growth stimulators to try to stimulate some of that bone to grow and provide that optimal spinal fusion for them. You can read a little bit more about this surgery on page 466 of your Kisner and Colby book. A discectomy or a microdiscectomy is a minimally invasive procedure. Basically, this is going to be a surgical removal of part or an entire herniated intervertebral disc. Okay, so an interbody cage fusion is an implant that is filled with bone graft and then inserted into that empty space where the disc was removed. The bone graft is then going to grow into and around the cage to create a stable area. So these are the implants that you see here. They remove the disc that is in between here, and they go ahead and insert these implants. And then we talk about laminectomy. A laminectomy is the complete removal of the lamina, also the spinous process. It basically decompresses the spinal cord to relieve some pressure that is being put on by those areas. This can be done if the patient is having a severe case of spinal stenosis. Sometimes it's done with spondylolisthesis, or sometimes with a herniated disc if it is affecting that much. Depending on the amount of bone removed, the procedure may need to be done with spinal fusion to prevent instability, because we're removing this whole area here that you see in the picture on the bottom right corner. So we need to provide some type of stability. So what they do is maybe they will use a cage in this area here to provide a fusion to this area and provide more stability, because the lamina was completely removed. The spinous processes was completely removed. So this area here is going to be unstable. So sometimes it is combined with a spinal fusion. And then finally, we talk about a vertebroplasty and a kyphoplasty. These are the procedures that are used specifically for, or generally used for, patients with osteoporosis that get those compression fractures that we talked about before. It can be a vertebroplasty, which basically is the bottom left-hand corner. You see a vertebroplasty. It's basically an injection of cement into the compressed vertebral body to kind of increase the height of the body and provide more support. So they're injecting cement in here into this fallen or compressed body, vertebrae, and then they're going to inject it, and that's going to increase that height. So it's quick setting bone cement that is injected into that area. Then when we talk about a kyphoplasty, please know the difference between the vertebroplasty and the kyphoplasty and what it is used for. So with the kyphoplasty, we're using balloon tamps to create a hole, a bigger hole in the vertebral body. They go in with this deflated balloon, so to speak. And then when they're in there, they're going to go ahead and inflate it to kind of create that higher vertebrae because it's been compressed. Now the balloon is going to be removed because they've already created that opening in the vertebrae. Now, when the balloon is removed, they're going to go ahead and go back into the opening that they just created to fill it with cement. Okay, so it's basically they're going in with an empty balloon, blowing up the balloon, taking out the balloon, going back in with the cement to fill the area that the balloon just opened up, which means that they increase the height of the vertebrae, and that is the procedure, to increase the height of the body. All right, guys, so that's the end of the cervical and lumbar spine lecture.